Is this? Yeah. Okay, Faith, thank you very much for that nice introduction. My lecture is in English. I am Afrikaans, and it's not a problem for me to speak Afrikaans, but to teach or give presentations in Afrikaans is nowadays quite difficult. I want to thank you all for inviting me. Paul took a chance, so I hope, Paul, that the chance you took comes off. And I must also thank the organizers for the kind way that we were received, Elna and her team. So for that, thank you very much. And now, let me just start off. I'm not going to read through that. I'm going to talk while you read through what I'm going to cover in this presentation. But there are things that you should know about me so that there are no issues about who I am, what I know, and what I don't know. I worked in Weskoppies Hospital during the peak of the COVID pandemic, and I'm still working at Weskoppies Hospital. We had to change everything. All of a sudden, I became a general practitioner. Together with my registrars, those are the people that we are training to become psychiatrists, we all of a sudden had to look after ill people. So I was one of those guys in that, that suit with all the protective gear and the helm and all the rest that went into the wards where we had numbers of COVID ill mentally patients. COVID infected mentally ill patients. There was no other way that they could be managed. They could not be managed outside, and only the very ill were sent to a different hospital, usually in our case to Kalafong Hospital. So I know about acute COVID. My poor physician colleagues heard from me every day because I was the consultant there, and of course I'm responsible. At the time I was also acting head of department, so that was a double whammy. I really didn't sign up for it. But that's the way things go. Now, while we are in a kind of a lull, I can't say that COVID is past. No one can say that. We don't know. We feel more certain, but I can tell you, we don't know. I do not treat people with long COVID. I was willing, after speaking to Paul, to look up everything about long COVID and to come and present here what I've understood from it. And what I understood from it, you will see, is that psychiatry has a definite place. I'm not going to jump the gun by saying what that place is, but we have a place, and there are things we can say as guidance. And that is what I hope to bring to you today. I guess the first question is, why should we talk about long COVID at all? And here's something that I recently pulled from WebMD. It's 2022, September. This is what Maggie Fox had to say. And this is talking about long COVID. It can be utterly debilitating or mildly annoying, and it is affecting enough people to cause concern for employers, health insurance, and governments. What does that mean? It means that some people who had acute COVID are now sitting with problems that are really cause for concern. The question is, how many? We'll come to that. And here's a quote from a patient, Claire Siboney. People tell you things like you should be grateful you survived it, that is acute COVID. And you should. But you shouldn't expect somebody not to grieve after losing their autonomy, their career, their finances. And now you can start seeing where psychiatry comes in. Here we are dealing with a devastating consequence to an illness in someone who was previously well. We are talking about life-changing issues here. Here's an idea of numbers. We don't know what the numbers are in South Africa. I tried to find it. We don't know. Up to 2 million people in the UK have at least one COVID-related symptom which lasted more than 12 weeks. I made that 12 weeks in red. The reason for that is what these authors basically say is that 12 weeks is their idea of long COVID. And one of the issues I will tell you is the definition of long COVID. 12 weeks is now one number that you have in your minds. Here's another reason we should talk about it. Desperate long COVID patients turn to unproven alternative therapies. And of course they will. They're desperate, they're in pain, nothing works, they've been to this doctor and that neurologist and this and that, nothing works. Of course they will turn to unproven therapies. Now you know that while COVID was going on, there were lots of, I call them pseudotherapies, being touted around in various ways. The ivermectin story, you will remember that. And it has never been proven to be efficacious. Now, when I say efficacious, and this is something that I want you just to keep in mind all the time as I'm speaking, efficacious means that under controlled research, an intervention or a drug is better than placebo or a waiting group or whatever the case may be, depends on the study. That is what efficacious means. And when I'm talking to you today, that is what is in the back of my mind about efficacious treatment. That does not mean that someone took ivermectin and is very happy with the results. That does not mean that someone tries something for long COVID, and it works for that person. Look, if you have a severe flu and you take lemon juice one morning and the next day you feel wonderful, good for you. But if I take lemon juice and water that is made to taste like lemon juice, and I take tens of thousands of people and I check what happens to their flu, I will find, hey, there's no efficacy in the lemon juice. All right. And I think all doctors also become desperate. I know, I work in psychiatry. Many of our patients simply don't respond, and you just try things. And then one day something works for a patient, and you think, wow, I'm onto something here. And the next 100 patients you see do not respond to that same treatment. Okay? Effective for that single person, not efficacious over a whole population. So keep that in mind. So if I'm telling you now this or that about the treatment of long COVID, and you say, but this person used that and they were better, oh, well, good, I'm very glad for that person. But it has not evidence base for efficacy. So just keep that in the back of your mind. So what is this thing called long COVID? Oh, well, there are many names. The official name is post-acute sequelae of SARS-CoV-2, but if you go and search that, you won't find much. So I searched long COVID, and that's where I got most of my information from, and so I'll be talking long COVID. I'm not going to bother to use the official term. What is long COVID? Now, there's another red lined time 4 or more weeks. That's according to the Centers for Disease Control. They've already had 12 weeks. Let's go to the World Health Organization. 2 months. So, you can see, we don't even agree on the definition of long COVID. Now, of course, in my group of colleagues, people became infected as well. I was one of those who was lucky enough to not become infected, or at least not that I know of, since we also know that many people are asymptomatic. But, yeah, what was my point? The point was about the times, of course. For me, as a psychiatrist, 4 weeks and 8 weeks, that's not time. Not in psychiatry. At least not in the psychiatry I practice. Now, I practice at Weskoppies Hospital, where we sit with chronic, severe, ill people. And if someone responds within 4 weeks, I'm so happy. Good grief. I've had flu where I had niggling symptoms for longer than 4 weeks. I didn't call it long flu. So what is long COVID? To me, it sounds like something that really continues for a very long time. So 12 weeks is more my idea of long COVID. But I'm not going to say that is the formal definition, because it is not. What do we know about long COVID? Not much, as you will see. But here are some of the knowns. 10% of acute COVID cases become long COVID cases. Now, but remember the 4 weeks? So we must factor that in. So many of these people who are called long COVID may now be quite well. We don't know. It targets various organ systems. I'm going to come back to that. But, and this is to keep in mind, these are the most frequent symptoms people have. Please understand, I'm not saying these are the only symptoms. These are the symptoms you, in your profession, are most likely to encounter, either in yourself or in the people that you serve. Compromised lung function. That really doesn't come as a surprise, does it? After all, COVID is a respiratory disease. Neurocognitive alterations. That hit me as a surprise when it was first described. Cardiovascular alterations. That also hit me as a surprise. Fatigue. Fatigue wasn't a surprise. How does this long COVID disease develop? Well, there are many causes, or no, that's not the right word. There are many things that contribute to long COVID, and I will just list them there quickly because I do not want to spend time on things which actually are still being disputed. But these are things at least that we know happens anyhow. Whether it's the cause of the symptoms of long COVID, that's a completely different question. The virus can persist in different organs. We know that. It's been shown. COVID doesn't leave the bodies of everyone. Mostly it does. But there are some viruses that get into your body and they stay. Herpes is one of them. HIV is another one of them, just to give examples that are quite common. it can cause the activation of other viruses in your system that doesn't go away. So that's another possibility. Autoimmunity. So give me a moment to say what that is all about. Everyone knows about the immune system. Those are the good guys, and the good guys fight the bad guys, the germs and stuff that come into the body and make us ill. And then sometimes the good guys become the bad guys. So the immune system turns in on yourself. And instead now of getting rid of germs and the like, it targets your own body tissues and damages them, and that can be done to a severe degree. Uncontrolled inflammation, well, that's another theory. A kind of inflammation that should have stopped, but the process just goes on and on. Now, inflammation is a very complex thing and involves many factors, and I don't even know all of them, and I'm not going to go into that. Here's the thing, and this is one of the take-home messages from my side. I was chairperson of the vaccination task team at Weskoppies Hospital. Did you see how my job description changed? Vaccination reduces the risk of long COVID if later infected. The specific vaccine does not matter. What does that mean? It means that if you were vaccinated and continue with your boosters and whatnot, the chance of developing long COVID is reduced. It doesn't mean the chance is zero, it's reduced. So getting vaccinated is just well worth the while. Now, a few unknowns. We don't know exactly how long COVID develops. You'll get people, as always, who say they think, who say they know. We don't know. We don't know the role of genetics, if any. We don't know the actual impact of vaccination on breakthrough infections and its duration. Well, that is not really about long COVID. That's more about if I had a vaccination and I get COVID, what does vaccination do? It seems logical to think it should reduce the severity of the illness. And from what I've seen, it does. But we don't really know everything. Future variants. There's a variant going around in Europe now. What's it going to do? We don't know. And worst of all, we don't have evidence-based, now remember what I said about evidence-based stuff? We don't have evidence-based information regarding the prevention or the treatment of long COVID. That's the bad news. There are risk factors for developing long COVID. Female sex. Now, you all know that acute COVID is worse in males than in females. Females in general did better when they had COVID than males did, in general. But that goes for other viral infections too. For example, flu and colds and so on. You men here know that women talk about man flu. It's a real thing. If someone had severe COVID, that is a risk factor. So we know that. Obesity, we know that. Disorders of fat metabolism, we know that. And we also know that those were risk factors for severe acute COVID. A history of a mental disorder, that came as a surprise. And then I thought about it and I thought, you know what? If one of the possible mechanisms of long COVID is inflammation, then of course, having a mental disorder would make a person more at risk. because many of our mental disorders are associated with dysregulated inflammation and stress responses. Hypertension, another condition where there is abnormalities in the inflammatory response. Dysgeusia, well, having acute COVID, those guys who couldn't smell and taste. And strangely, younger age. Isn't this an upside-down condition? Understanding fundamental mechanisms underlying the pathogenesis of long COVID is in its infancy and represents a major challenge. Ladies and gentlemen, that is academic medicine for, I don't know. Let's have a look at the clinical features. How do people with long COVID present? And I'm not going to go into this in detail because it is impossible. And the reason for the impossibility is because so many organ systems are affected. I'm going to sort of stick to my area with neuropsychiatry. Here's something again from WebMD, very recent, 29 September 2022. Eric Roach became ill with COVID-19 in November 2020. Now remember, this is now 2022. And he is still sick. I have brain fog, memory loss, says the 67-year-old Navy veteran from Spearfish. The fatigue has just been insane. Fatigue. Let's just clarify something about fatigue. Let's clarify it by comparing it to shortness of breath. Not the same thing. With shortness of breath, I walk a few steps and I'm out of breath. Or I feel short of breath all the time. But once I sit down and relax, I'm okay again. Fatigue is this ongoing feeling of being pasted and I just can't get going. That's fatigue. Everyone here must have had fatigue at some point in their lives. Another patient speaking. I feel like there are two me's, the me before COVID and the me after COVID. I don't even recognize who I am anymore. So this speaks to the people with the debilitating long COVID disease. I'm not going to reiterate that. Multiple organ systems. And because of that, all sorts of symptoms. Let's just run through them quickly. Tiredness, shortness of breath, loss of smell, muscle aches, problems with memory and concentration, chest pain, tightness, difficulty sleeping, palpitations, dizziness, pins and needles, joint pain, depression and anxiety, tinnitus, that is ears that are ringing all the time, ear aches, feeling sick, diarrhea, stomach aches, high temperature, cough, headaches, and it goes on and on and on. After 1 year, and for me, being a psychiatrist, especially a neuropsychiatrist, where things move very slowly, if at all, 1 year kind of sounds, okay, we're talking now. Now we're talking. Main symptoms after 1 year: depression, right? Psychiatric symptom. Anxiety, psychiatric symptom. Memory loss, neuropsychiatric symptom. Concentration difficulties, neuropsychiatric symptom. Insomnia, psychiatric symptom. Fatigue, neither here nor there, physical and psychiatry. Breathing difficulties, respiratory. Muscle and joint pain, musculoskeletal. Most of those fall into the category of neuropsychiatric symptoms and signs. Here is an estimation, Estimations are just that, they're estimations. They're not hugely researched outcomes. Up to 60, well, 2/3 have some cognitive dysfunction. We'll come back to that. Anxiety is quite common, mood is quite common, insomnia is quite common, and then dementia. 1.6% of people over 65. I'll come back to that. Cognitive dysfunction. Now, cognitive, of course, refers to the way we think and what's going on in our minds. Attention. Attention problems, yes, common. Executive functions. Now, executive functions are that part of our brain that helps us to do problem solving, plan, make decisions, keep track of things that are going wrong and immediately correct them, and so on. When it goes wrong, it is really a problem. Because how do I do those things? Yes, it is affected in long COVID. Now, there are studies that indicate, and I mean, you don't need too many studies for this, there is central nervous system damage consequent to COVID. Not in all people, but at least in some of them. Now, I'm saying this to help you understand that we're not talking about people who just are making use of symptoms to get away with something. That idea is usually wrong. Remember it. I'm telling you here that both white cells, no, not the white cells, the white matter and the gray matter in the brain are afflicted by COVID infection in some patients. That having been said, please, if you do have long COVID, don't look at that and now think, oh, I'm brain damaged. I work with that. People who consider themselves damaged goods. Watch out for that kind of attitude, because the majority of symptoms and disabilities after a head injury is not related to the damage to the brain itself. There are socio-cultural factors that come into play. Now, of course, if the brain is damaged beyond a certain limit, yep, it's brain damage. And about that, well, there's very little we can do, can we? The cognitive dysfunction can affect young people too. That was quite a surprise. The rest you already know, the memory impairment, the frontal lobe dysfunction, that's now the executive dysfunction I talked about. Memory impairment, quite common as you can see there, and it affects both long-term and short-term memory. Now we come to treatment. So let me read this to you. Guidelines on evidence-based multidisciplinary management for long COVID conditions are limited in the literature. That is academic medicine for, I don't know. Okay. While there's a newly emerging body of research testing interventions for mental health, cognition, and psychosocial well-being in long COVID, the breadth and scope of the research remains limited. That is academic medicine for, I don't know, but we're working on it. Now, if you want to go the complementary and alternative medicine route, these guys are also honest enough to say, we don't know. That's basically what that says. So here we sit with a condition where we really don't know what the best thing is to do. And that's why I, as a psychiatrist, can come in and say, hey, maybe I can say something here. And we're then going to make use of principles that work for any chronic condition, and we see how we can work with that. And it is not easy. It makes sense to start with a GP. Although I told you now that the neuropsychiatric symptoms are common, there are many other body systems that are affected, and yes, start off with a GP. From there, the GP can see what he or she can do or refer, and one can look, maybe there is something that is best for this person. Hey, maybe there's something you never knew about. It's not even COVID. From there on, it's a symptom-based approach. Now, in psychiatry, we know all about symptom-based approach because that's what we do. It's a symptom-based approach. And of course, it may involve multiple disciplines, both the physical, psychological, and psychiatric parts of patient care. There are good websites with advice for patients. There is one. Now, I don't expect you to remember that off by heart. For those who can, go ahead, photograph it in your brain and keep it. But I'll make it available to you guys if you want to afterwards. But now I'm turning to these websites. I'm reading them, and I'm telling you what I get from them. I also looked at religion and spirituality. No, I'm not going to teach you your job. Basically, I took one good review. I'm going to quote from that review, and I'm going to tell you what you already know. But I thought, you know what? During a congress like this, sometimes you must just hear again what you already know. And I'm basically going to confirm to you, you've got a role to play, you make a difference. Now, with religion and spirituality, there are both positive and negative aspects. So let's just have a look at them quickly. I'm not going to stay on this for too long. The grounding effect. During disasters and other traumatic events, this grounding effect is a vantage point for individuals to create meaning out of seemingly meaningless pain and suffering. I'm going to talk about meaning again, but not much. So let me say my say here and get it over with. Meaning is one of the existential concerns in life. And many people are unable to make their own meaning. Religion, spirituality is one of those meaning-making mechanisms. And there's no doubt that it works. This is your role. Helping patients to make, or in your case, your congregation members, to come to some form of meaning out of this disaster. There will be questions like, how can a loving God do this? And so forth and so on. I'm pretty sure you've heard the stories already. Powerful source of hope. You'll know that. Powerful source of affirmation. Affirmations would be verses from the Bible that holds a specific positive emotion. The Lord is my shepherd. I shall not fear. And many others. I'm just giving you an example. You'll know better than I do. Religion and spirituality is especially helpful in situations where there is little control. So you must just find people coming to church who you haven't seen for a long time. Meaning-making of suffering may be a core contributor to resilience. I've said what I wanted to say. coping and adversity literature, well, you will have your coping and adversity literature. Those books that one gets that helps one through difficult times. Some of them are extremely good. I've read them. Keeping the faith. Now, the last thing you want your COVID congregation member is to lose faith. With that goes hope, with that goes meaning, and then in marches the possibility of severe mental disorder. On the negative side, you'll know this too. Rejection of the diagnosis. Yes, rejecting treatment. Don't go for your injection. Unfair criticizing. Hey, lazy bones, get up. Get moving on. God is punishing you. You just have to pick yourself up by your bootstraps. Come on, come on. You're putting on. Yes, happens. And then I've already said the belief about this is God punishing me. If a person says, this is God punishing me, think possibility of a severe clinical depression. Just think it, because it's one of the symptoms. Here's another web page that you can go to. This is specifically for patients, and again, I'll make it available if you think it might be worthwhile. I've taken that and I have divided their advice into inner work and practical stuff. And unfortunately, the first one is now there. The inner work consists of 3 things and the practical stuff a lot more. The inner work is the most difficult, but probably that's where you will have to start. And the first thing is acceptance. Now that's the only thing you really read in this site, so I'm going to elaborate on acceptance, because this is the gate you have to pass through. Acceptance here does not mean throwing in the towel. Acceptance here means something like, who knows Stephen Hawkins? Yes. A man with a severe neurological condition who became a renowned physicist, despite his disability. That's what this acceptance is about. So I'm going to talk from a form of psychotherapy called acceptance and commitment therapy. And here, acceptance is about accepting the condition you have, or accepting up to the point that you can. I'll give examples of that just now. And then committing yourself to living your values. You will know all about values. What are your values? Write them down. Make a mental note on a piece of paper. Don't keep it here. Write it down. How will you live if you live your values? Write them.
Dankie, Professor.
Okay,
Pierre.
there we go. So I was talking about acceptance and commitment, and the last thing I said was write those values down on a piece of paper, and write down on a piece of paper what it will look like if you live those values. Don't be vague, be specific, and be realistic. So that is what we mean by acceptance. Now, there are levels of acceptance. I can, for example, say, I don't accept that I can't do these things anymore. I can't accept it. But then there's a next level. It's a bit tricky, but there is a next level. I can accept that I don't accept my limitations. At least I can accept this. And from there on, I can still say, these are my commitments. These are my values, and this is how I'm going to work about. This is what I'm going to do to live those commitments. But acceptance is probably the most difficult thing. It's life-changing, and you can imagine that someone who's been very active and all of a sudden has reduced lung function, and I'm keeping it physical here, how difficult it is to adapt to that. But if it's your new truth, then it's your new truth. And this also, I think, is where you guys come in. Meaning making, keeping the faith. Some more inner work. Be kind to yourself. We grow up in a society where we are achievement-oriented. And everyone here will know what I'm talking about. Achievement is the thing. Failure is a no-no. And in that context, we are criticized as kids. Why can't you be like so-and-so? You should do better. And those criticisms become our own. And now all of a sudden, in a condition, under circumstances completely out of your control, by the way, ACT is made. Acceptance and commitment therapy is made for those you have no control over this anymore. Conditions, I forgot to say that. You've gone for this kind of therapy and that pill and what have you, nothing works. So now this is where you are. Back to kindness to yourself. So here we are talking about, okay, I accept I have these limitations. Now let me be kind to myself. And one can be kind to yourself in many different ways. And we'll come to that when it is about the practicalities. But the first thing is the inner talk. If you're telling yourself, I'm useless, I'm a no goodnik, I'm of no value anymore, that's not being kind to yourself. That's being harsh on yourself. A kindness would be, hey, you know, I'm still here, I can still do things. True, I've lost some abilities, but look at this, I can still do this. I don't know whether you've seen that cartoon. There's a little boy, and he's angry, and he sits like this, and he says, I know I'm somebody because God don't make no junk. This is the kind of thing, being kind to yourself. Listen to your body. Part of the kindness. If you're tired, you're tired. If you can't concentrate anymore, you can't concentrate anymore. Take it easy. Back to kindness. Back to acceptance. Acceptance is the door. Now let's go to the practical stuff. And hey, the practical stuff is not difficult. And most people will be able to just work it out by themselves. Prioritize. What are the important things in my life? You've got your values, you've got your commitments, prioritize. What must be done today? Let's prioritize. Look for easier ways to do things. We often want to do things the most difficult way possible. Simply to say, hey, I've done it. Isn't there an easier way to do things? Tell people about your limitation and ask for help with tasks. That is also being kind to yourself. Unfortunately, for those of us with an alpha type personality, it's going to be difficult. Acceptance, move beyond it, new life, let's do the best we can. Some more practical stuff. Scheduling of tasks. Comes back to prioritization, isn't it? Write down, I want to do this, then so and so and so, and give yourself enough time. Why schedule? Because it gives structure, and if you have some difficulty with memory, it aids. Graded activities is basically start doing things, but do it slowly. Now here's the thing. Graded activities work. How do I know that? Hey, I've had many patients. You know those depressed patients who can't get up out of bed? Graded activities. The thing to remember for the rest of my talk is the brain is much like a muscle. If you don't use it, it atrophies, it shrinks. If you use it, it gets stronger. Our bodies are amazing. The brain is highly complex. And here's the thing, it makes new connections, and with those new connections, new areas are called upon to do tasks that areas that don't function so well, the task can be taken from. So make use of that, but take it slowly. Intend for your brain to do things that you want it to do, but take it slowly. And get an occupational therapist to help you if needs be. Keep a diary of activities. It will show progress. I think it's a good idea. So I've done this today, and so forth and so on. Again, back to that, accept and commit. Reward yourself for completing tasks. And this is something that I guess we really have to learn to do. What are the things you enjoy? Reward yourself with that. What I have here as an activity task schedule, I'll quickly tell you what this is about. You can now populate that activity schedule in any way you want. And you see there M and P. M stands for mastery and P for pleasure. This is something that we use in cognitive behavior therapy. It's not copyrighted. You can take it from there. And it is a way for people to see progress. At first, that patient that I told you about who couldn't get out of bed, gets out of bed, brush the teeth, and go and make something like breakfast, and that's it for the day. And he or she rates mastery as 1 and pleasure as 0. But as the time goes on, it has a kind of self-reinforcing effect. It gets better. Avoidance maintains symptoms. Now don't take that too far. But if I avoid doing things, it will maintain whatever symptom I have related to that avoidance. Now I'm not saying go and do stupid things. But if I don't want to get up out of bed, then getting up out of bed is the thing, because staying in bed is going to maintain staying in bed. There are academic reasons for it, but those are not important. If I have a fear of, say, going in an elevator, then going onto the elevator is the way to overcome it. As long as I don't do it, it will maintain my fear. That's what I'm trying to say with avoidance maintains symptoms. And scheduling tasks help to overcome that. It's a kind of exposure. Keeping active, yes, same thing. Staying active to the degree you can, as best you can, helps to reward oneself for doing things. Do things you enjoy. Do things that are relaxing. Now, there are different strokes for different folks. I don't know what you enjoy. I don't know what you find relaxing. You will know. Your congregation member will also know. With focus. Now, this is what the website gives. Find a quiet place. I agree with that. Find a quiet place. Ask people don't disturb you, because you're now going to sit in that quiet place and you're going to do exactly what I said is a good idea. Practice your brain. Exercise your brain. Do weight training for your brain. Ask people not to disturb you. Take regular breaks. Do puzzles like Sudoku or crossword puzzles, but I mean those are only examples. One finds a lot of intriguing video games that target memory, that target word finding, and all kinds of things. Hey, play those games. Take it slowly. And know your limits. And don't push yourself. Be kind towards yourself. In that way, you're going to exercise your brain. So those are very practical things to do. I once had a medical student who suffered from major depressive disorder, severe. And in those days, we still saw medical students. I mean, I'm talking decades ago. And she said she can't study. Now, the problem with major depressive disorder is it really knocks your ability to attend and concentrate severely. And that's what happened to her. Now, COVID can do the same thing. So, we collaborated. I don't tell her, do this, do that. We collaborate. So, if you don't study at all, and you come sit here with me and you study for 15 minutes, that would be a huge step forward, wouldn't it? Yes. Came and did that. And okay, the rest speaks of itself. It goes from there. Practicing the brain and going forward. If you should have one of these games and things, you will probably notice that after a while, your concentration goes. If it happens, note the time. That's your limit. Take a few minutes off from that. Take a break, and then start again. Here's the thing. There's something called concentration collapse. Anyone here who plays chess? Ah, okay. So you must have looked at Grandmaster games. Now, you know those games go on and on and on. So those are Olympic-type concentrators. And this wonderful Grandmaster plays and plays and plays, and then towards the end, they make the most stupid mistake, a blunder that I won't make. And that says a lot. Concentration collapse. You don't know when you have concentration collapse, but the results show it. So check what your limit is. Keep there, rest for 5 minutes, 10 minutes, start again. Don't take too long. You see, your brain warms up like a muscle. And if you get to the point of concentration collapse, it is already a little bit too late. That's like when you go and you over-exercise. It takes a long time to recover after you over-exercise yourself. But if you take a time years break and you go back, hey, sharp. As I told you, not much difference between some aspects of brains and muscles. Now, for anxiety, depression, and worry, They give basic behavioral techniques and basic cognitive restructuring and basic advice against avoidance. Of course, they would. Now, I can't give you that. That'll take too long. And quite frankly, if it is needed, you will probably need professional help. So go and look out there for a clinical psychologist who does cognitive behavior therapy, because psychodynamic psychotherapy is not going to work for this. Memory. Well, yes, you can exercise your memory. I've told you about that. And in the meantime, just make notes. That's one of the reasons for an activity schedule. Wake up in the morning, this is what I must do today. Or I'm going shopping, this is what I must get at the shop. So use your brain to help itself. And making notes is one of them. I'm talking you here all the time, but at the back of my mind, when I was working on this lecture, I saw you with your congregation, going to their homes, listening to their stories, and then collaborating with them in terms of what can be done better. Meditation. Meditation is not mentioned. There's no evidence that meditation works. I think for those of you who already has a kind of meditation practice, I'm not talking about just a bit of mindfulness here or there, a meditation practice, or a contemplative practice, this is something that can certainly help. It's a brain exercise. So, yes, of course, it can help. And that, ladies and gentlemen, is the end of my lecture.